Hello all, today we will discuss about osteoporosis. Osteoporosis is a progressive systemic skeletal disease and it is due to reduced bone mass or bone density and the microarchitectural deterioration of bone tissue occurs. Here we can see in the picture a healthy bone compared to the osteoporotic bone. WHO definition of osteoporosis. If a person has a bone mineral density measurement T score at any site less than 2.5 standard deviations below the young adult standard, the diagnosis of osteoporosis can be made. So T score less than 2.5 standard deviations below the young adult standard. Pathophysiology. Reduced bone density occurs and that causes microarchitectural deterioration of bone and that predisposes to fractures. And here the imbalance in bone remodeling cycle occurs and the osteoclast activity will be more than the osteoblast activity. Risk factors. Age. As age increases, risk of osteoporosis increases. Then female gender. Then calcium deficiency. Genetics. Single gene disorder like estrogen receptor mutations and polygenic inheritance. So, if there is family history of osteoporosis, then there is increased risk for osteoporosis. Then endocrine causes like hypogonadism, hyperthyroidism, hyperparathyroidism, Cushing syndrome. Inflammatory diseases like inflammatory bowel disease, ankylosing spondylitis, rheumatoid arthritis can predispose to osteoporosis. Then drugs predisposing to osteoporosis, glucocorticoids, systemic glucocorticoids, long-term use of heparin, anticonvulsants like phenytoin, barbiturates, carbamazepine, chemotherapeutic agents, aluminum containing antacids, gonadotropin releasing hormone that is GnRH agonist, and levothyroxine over replacement, aromatase inhibitors, thiazolidinediones. Gastrointestinal disease like malabsorption, chronic liver disease can predispose to osteoporosis. Lung diseases like COPD, cystic fibrosis can predispose. Other causes like myeloma, chronic kidney disease, homocystinuria, HIV, Gaucher's disease, autoantibodies to osteoprotergerine. Then malnutrition, BMI less than 18, anorexia nervosa and highly trained athletes are prone for osteoporosis. And immobilization is an important cause for osteoporosis. Heavy smoking, alcohol, exercise and calcium intake during growth and adolescence can maximize peak bone mass and thus decrease the risk of osteoporosis. Then pregnancy associated osteoporosis. It is rare and presents as back pain, multiple vertebral fractures during second or third trimester. Cause is unknown and here exaggeration of bone loss that normally occurs during pregnancy in patients with pre-existing low bone mass. Clinical features. The bone fragility causes susceptibility to fracture. Then osteoporotic or fragility fracture occurs. So fragility fracture means fracture that occurs as a result of a fall from a standing height or less. Common sites: forearm, Colles fracture, spine, humerus, hip. And the fracture causes pain, tenderness, deformity. And the vertebral fractures causes height loss, kyphosis, chronic back pain. Investigations. DEXA scan or dual energy X-ray absorptiometry scan assess the bone density. It's an important investigation and here it assesses the bone density in hip or spine and the report is given as T-score and it compares to that of healthy young adult. And plain X-ray, here also we can see the cortical bone and we can also identify fractures. Other investigations to rule out secondary causes: CBC, ESR to look for IBD, myeloma, urea creatine electrolytes, CKD, LFT for CLD, serum calcium phosphate for primary hyperparathyroidism, serum vitamin D ALP for vitamin D deficiency, osteomalacia, serum parathyroid hormone for primary hyperparathyroidism, thyroid function test for hyperthyroidism, and serum protein electrophoresis for myeloma, monoclonal gammopathy of uncertain significance, tissue transglutaminase antibody for celiac disease, urinary Bernstein's protein for myeloma, testosterone gonadotropins for male hypogonadism, estrogen gonadotropins for female hypogonadism. Then quantitative CT scan, that means CT scan plus the use of computer software to assess the bone density, and the bone density is assessed in spine. Then other test is quantitative USG of calcaneus. It is cheap test, but it is not accurate, and it can be used for general screening, and it is portable. Then next important one is WHO fracture risk calculator. So that is called FRAX, and it calculates 10-year probability of a major osteoporotic fracture. Next, management. So management for fracture prevention and screening, and non-pharmacological and pharmacological managements are there. First, non-pharmacological management: regular exercise, weight-bearing activities, walking, cycling, swimming, etc. Then diet. So we should try to maintain BMI between 20 to 25 kilogram per meter square, and increase more calcium-rich diet. Stop smoking, decrease alcohol intake. So about calcium, it can be included in diet or or taken as supplement. The dose is 1000 mg per day for 51 to 64 years and 1500 mg per day for more than or equal to 65 years. And for pregnant or lactating women, dose is 1200 to 1500 mg per day. And next is vitamin D3 or cholecalciferol. Required dietary amount is 400 international units per day, and 800 international units per day to be taken in case of osteoporosis. And estrogen supplement can be given for postmenopausal ladies. And for primary prevention, first we have to do risk assessment with age, sex, and the FRAX score. And DEXA scan can be done if there is high risk for fracture. Secondary prevention, if already have osteoporotic fracture, if more than 75 years, we can tell the fracture is due to osteoporosis. But if it is younger, then we have to do DEXA scan to confirm osteoporosis. Then bisphosphonates. Bisphosphonates is an important drug in the treatment of osteoporosis. Alendronate 70 mg per week and risodronate 35 mg per week orally, and it should be taken in empty stomach with plain water, and no food to be taken for 30 to 45 minutes after. And duration about 5 years. It can be used for about 5 years, and after 5 years we may have to change the drug or have to stop the drug. And side effects: gastritis, erosions of esophagus. So we should advise the patient to remain upright for 30 to 60 minutes after taking medications. And also don't use proton pump inhibitors for the treatment of gastritis due to bisphosphonates. Next, solendronate. It is given IV as a single IV infusion once a year, and ibandronate, it's given as IV every 3 months. And adverse effects: esophageal cancer, osteonecrosis of jaw, mandible and maxilla, atypical fracture, atrial fibrillation, uveitis, scleritis. Next drug is raloxifene, that is selective estrogen receptor modulator, and it is a partial agonist at estrogen receptors in bone and liver. Can be used in postmenopausal ladies. It reduces risk of vertebral fracture, but there is side effect of risk for venous thromboembolism. Next one is strontium. Adverse effect is a risk of venous thromboembolism and cardiovascular events and rashes. Next one is a monoclonal antibody, denosumab. It is given subcutaneous twice a year. Dose is 60 mg every 6 months, and it neutralizes effects of RANG ligand, and it reduces the osteoclast activity. Adverse effect is hypocalcemia. The next drug is romosozumab. It is antibody against sclerostin, and it is under trial. Next one is teriparatide. It is parathyroid hormone peptide anabolic, and it stimulates newborn formation, and it's given as sub-Q, and the dose is 20 microgram daily for 2 years. and it should not be given with bisphosphonates. Next one is hormone replacement therapy. Cyclical hormone replacement therapy with the estrogen and progesterone can be given for postmenopausal ladies, but it should not be given for more than 60 years age, because of risk for breast cancer, cardiovascular disease, and risk of venous thromboembolism. Next, surgeries for fractures like internal fixation, hemiarthroplasty for hip fracture, total hip replacement for hip fracture, vertebroplasty. Thank you.